So the first one we have Dr. Sandeep Vaidya, who is from Mumbai, Thane, and he's attached to prestigious Sandeep Vaidya Hospital for Children, and he's also attached to Pinnacle Hospital, Thane, and Jupiter Hospital. Let's invite our first faculty, Dr. Sandeep Vaidya.
Thank you, madam. Good morning, everybody. So in this first talk, we are going to revise and brush up our basics, and this is a brief outline of the topics which I am going to touch upon. So to start off, in any supracondylar humerus fracture, it is good to first classify the fracture according to the direction of displacement, because this tells us about the mechanism of injury and the reduction maneuver which is to be employed. So majority of the fractures are extension type, which can be displaced either in a posteromedial or posterolateral direction. A very rare minority will be flexion type. Gartland classification we are all well versed with. Type 1 undisplaced, type 2 is green stick with sagittal plane angulation, and type 3 is completely displaced. However, there are a few new additions to the original Gartland classification. So Wilkins subclassified type 2 into type 2A, that is pure sagittal angulation, and 2B, that is angulation plus rotation. An additional type 4 was added, which is a fracture with multidirectional instability. This indicates a circumferential periosteal tear. Therefore, these fractures are extremely unstable, difficult to reduce, and difficult to pin. Bahk in 2008 classified supracondylar fractures according to the fracture pattern. So majority of the fractures are typical, that is transverse in the sagittal as well as coronal plane. However, there can be a few atypical subtypes. So in the coronal, the atypical subtypes can be medial oblique, lateral oblique, and high transverse. In the sagittal plane, the atypical subtype can be sagittal oblique. The significance of identifying the atypical fracture patterns is that the reduction is difficult, these are unstable, and you may need to modify your pin configuration in order to achieve good stability. Clinical evaluation of supracondylar fractures must include a neurovascular evaluation. A quick neurological assessment for integrity of all three nerves can be done by asking the child to perform the gestures of rock, paper, scissors, and OK sign. The 3 A's of compartment syndrome, namely anxiety, agitation, and need for increasing analgesia, should be looked for. A contusion or pucker indicates that there is a possibility that the spike of the proximal fragment may have buttonhole through a rent in the overlying brachialis muscle. This is important to identify because this makes the fracture difficult to reduce. Then coming to radiological evaluation. So type 1 fractures, many times the fracture line is not visible on day 1 of injury, and in such cases you have to rely on elevation of anterior and posterior fat pads. Additionally, in type 1 fractures, you have to be careful to look for medial column comminution. In this rare situation, the fracture can drift into varus due to collapse of the medial column later on. Therefore, these fractures should be stabilized with K-wires. Type 2A fractures, you have to assess the magnitude of sagittal angulation, and that is done by looking at the orientation of the anterior humeral line with respect to the capitulum. If the anterior humeral line is intersecting the capitulum, these fractures can be treated with cast in situ. However, if it is completely missing the capitulum, these fractures must be close reduced and pinned. Type 2B fractures are identified by identifying rotation, which is indicated by differential width of the proximal and distal fragments. All type 2B fractures must be close reduced and fixed. Finally, coming to type 3 fractures, and the gold standard of treatment here is close reduction, K-wire, and cast. There are various options for OT setups and positioning of the child for this procedure. The steps of reduction, initial first step is traction against a counter traction applied by the assistant. The second step is correction of coronal displacement. And the third step is correction of sagittal displacement. This is done by applying thumb pressure to the olecranon and fully flexing the elbow. The reduction is then locked. This is done by pronation in case of fractures with posteromedial displacement and supination in fractures with posterolateral displacement. Intraoperative assessment of reduction is done by obtaining Jones view, pillar oblique views, and lateral view. Stabilization of a typical transverse fracture can be achieved by insertion of lateral K-wires. So the number of wires can be 2 or 3 depending upon the stability of the fracture. Out of these wires, the inner wire must pass through the olecranon fossa because this gives a stable forecortex hold. The outer wire is the pillar wire. Additionally, there must be sufficient divergence and spread between the inner and outer wires at the level of the fracture site. In the sagittal plane, the wire should pass from slight anterior to posterior. However, you may need to modify your pin configuration in case of atypical fractures. So for medial oblique fractures, you would need to insert medial pin. For high transverse fractures, you would need to insert intramedullary wires. And for sagittal oblique fractures, your wire orientation would have to be from posterior to anterior. So to conclude, you have to do a careful clinical and radiological evaluation to differentiate typical from atypical fractures. Type 1 fractures are almost always conservative except the rare situation of medial column comminution. Type 2 fractures should be close reduced and fixed if these fractures have excessive sagittal angulation and rotation. And type 3 fractures, close reduction K-wire cast is the gold standard. Thank you.